call on Dr. ANITA SETHI now. And Dr. ANITA is the director and head of the Department of Ophthalmology at Fortis Gurgaon. She's a versatile surgeon, both anterior segment and oculoplasty, and she'll be talking to us about hitting the bull's eye with multifocal lenses. And after this, I would invite Dr. Aditya Kelkar. He would be giving his keynote address.
Thank you, Dr. Ritu, for inviting me to be a part of this really interesting IC. And, you know, as Parul said, we've all struggled through all these problems. I have gone to conferences and gone from room to room only listening to Toric to know why are my patients not doing well. So we've all been through it. It's nothing to worry about. So, and the previous speakers have all made my job pretty easy because I'm basically going to take a lot of points from what they've said. And so is there a need for multifocal IOLs? Frankly, after becoming presbyopic myself, I hate my presbyopic glasses. I'm very good at counseling now because I really know what they're going to go through. We are getting cataract in younger patients due to diabetes, steroids, trauma. So leaving them with a plus 2.5 is really not a fair thing. And, you know, there are longer active working lives. Who wants to see George Clooney and Robert Downey Jr. with glasses? So yes, cataract surgery is refractive surgery, and we really have to move with that. Are multifocals the panacea for this? We have to understand the limitations of these lenses. There is going to be loss of contrast no matter how much our lenses have evolved. There is still division of light. It is better bilateral, but we are still quite far from having the ideal replacement. And there are visual disturbances, halo, sunbursts, and glare. We even have still dysphotopsias even with monofocals. So these are all part of the lenses. EDOFs might answer some of these questions, and that Dr. Ritu is going to tell us later. So again, I'm going to just repeat what Dr. Parul said, that patient profile is the most important part when you're choosing your patients for a multifocal. The age, the personality, very important. Unilateral young patient with a cataract is always going to be a problem because you can never match the natural crystalline lens, but you do want to give them as little dependence on glasses as possible. In refractive errors, I find the hypermetropes are most accepting and forgiving, and maybe you should start your multifocal practice with hypermetropes. And the myopes, because they can see without their glasses, and when you tell them, if we give you a monofocal, you won't be able to see without your glasses, they just don't get it. But Dr. Saab, I can see without my glasses. Occupation, those who have nighttime driving, all of this, and affordability, all said and done, the more the patient has paid, the more he is going to expect from you. So you need to be able to put all these factors together. Frankly, I found that older ladies, you know, who want to go for kitty parties, hypermetropes, they were my best place to start multifocals. So, you know, we should all be kind to ourselves. I think more important than the indications are the contraindications to the multifocals. Fussy personality, the auntie who wants you to sterilize and sanitize every part of your OPD and yourself before you touch her, better not to touch her at all. Retinal disease, glaucoma, yes, these are definitely not, they have to be ruled out. And as Dr. Parul said, we must do an OCT in all our patients, and we must rule all of this out. And night driving is also an important, there are people who drive a lot. They are going to be bothered by these photic phenomena. So these are the contraindications, and I think it's just best to stay away from them. So I'm going to just illustrate with 61-year-old musician who used to teach my daughter keyboards and had moved to the US, lots of driving. Now as a musician, he needs his intermediate vision, and he'd been advised all the lenses in the US. And just to add, he had a unilateral hypermature cataract and no pressure. And he said, Dr. Saab, you decide. Now, these are really difficult decisions for you as a doctor because, yes, they have faith in you, but, you know, you really can't, and they don't always understand when you tell them. So I gave him these two options. One is driving comfortably, no visual disturbance, but using a small reading number for near, which in my view is a correctable problem. Vis-a-vis reading comfortably without glasses, but some amount of visual disturbance while driving, which is an uncorrectable problem. And thankfully, he chose A, which I thought was also better for him, because it's better to have something you can correct. Don't promise no reading glasses. Tell them small reading glasses, but most of your work can be done. So it helps you choose the lens for the patient. Counsel the counselors, and actually for premium lenses, as Dr. Parul said, I counsel the patients myself, but also counsel the counselors because they like to go out and ask everybody in the OPD. We can only say a reduced dependence on glasses or an increased range of vision. We have to underpromise and overdeliver. We cannot promise the patients that they're going to, just because they spent more than 1 lakh, they're going to go back to vision of 25 years old. So I'm just going to highlight, Dr. Parul has already told all of this, but we must rule out subtle ERM, VMT, which sometimes are not visible to us anterior segment surgeons behind the cataract. The dry eye workup is so important. 6/6 N6 and Dr. Maza nahi aaya. It's just, you don't want to hear that. And we have to have a low threshold for toric. Dr. Nitin has really explained that very nicely. And I have myself 0.5 or 0.6 to 0.75 against the rule. That's my limit for multifocals. Wherever possible, get it done on 2 instruments. Please take into account the posterior corneal astigmatism. And I've been using immersion for a really long time, and it is as good as optical, but if I have a doubt, I'm going to send it to my good friend, Dr. Parul. And yes, if there's a doubt, and do the keratometry, different places, different people, just don't go in for a multifocal with a doubt in your mind. The next difficult question is which lens and which power. You do need to discuss the pros and cons of all the lenses. I've included EDOF here. It's not a multifocal, but sometimes it's just the better option, and it's part of your counseling. You really have to have a reliable biometry. Now, choosing the power of the lens, again, I choose it myself. I don't let the optometrists do this. And you have to see whether you want to take emmetropic power or the first myopic 0.2. And some of the multifocals have a very small landing zone. And actually, they advise you take the first hypermetropic, the first plus 0.1, 0.2. So it depends on your lens. And I discuss with the company people as well. And I'm very particular about the biometry. I find Barrett's 2 is an excellent formula, and the ASCRS for post-refractive surgeries is again a very good formula to use. So as already been said in the toric, first get comfortable with the monofocal toric. Once you're comfortable with it, you figured out how it works for you. It takes some time, nothing to worry about. We'll all get there, yeah. And make sure there's no rotation, incision on axis using flax. And then I always give a gap between the second eye. Sometimes you can make little mini corrections in the second eye. If your biometry has been a little off, if you feel that the patient is not doing as well for near, you can go a little plus. There are some lenses actually which are for the mini well lenses distance and different one for near. Earlier, Restore used to have different ads. So you can do a mini correction in the second eye, and we all know the multifocals will work best bilaterally, and we must always tell our patients that there is going to be some adjustment, and then when it's bilateral, it's going to get better. So this choice of IOL and choice of patient, the doctor should definitely, surgeon should be very much there. So in the surgical steps, there's nothing very much different other than you must know your SIA. Tend to make a smaller axis because you really don't want it to go out. It has to be well centered. And I would just add to what Dr. Nitin said about removal of visco. When I do my last removal of visco, I do the last positioning under irrigation. I use a dumbbell dialer. So yes, be about 10 to 15 degrees away. And then just when you think most of it is all out, the last rotation I'll do under irrigation and do it with a dumbbell dialer and then just leave it in position. Now, what do we do when there are refractive surprises? So this was a post-LASIK myope, and again, we emphasize we must ask the patient for previous refractive surgery. This lady had refractive surgery only on one eye and had omitted to mention it because it was 25 years ago. She thought it's not relevant. And as soon as I put the lens in and I told her that, oh no, you were so cooperative, she says, yeah, I've already had surgery before, so I'm going to be cooperative. So I just nearly died over there. And I raced out. Now I've done the surgery and we did the calculation and we found that we've put in 21.5 instead of 22.5. I said, okay, let's wait and watch. I didn't want to take it out for just one diopter. And the next day, patient was 612 N12, but happy because we had never promised her that you will be not, how you're going to be just a few seconds more. But her ventral refraction, and I waited for the other eye for a bit, she actually was with a plus 0.5 cylinder, 6 parts, and quite happy to use a plus 1.25 add. So this is a forgiving lens with a good defocus curve. I mean, there's a good landing zone. So this, you should know for each lens which has a better landing zone. And again, you should have a good friend. If you don't do LASIK or PRK yourself, you should have a good friend whom you can offer that option. And I found in the few patients where I do have a little bit of cylindrical for whatever reason or some little refractive error, when I offer them that, they say, no, actually, we're fine. The other eye is compensating. So mostly they're fine. And most people are not that fussed if they have to wear a little bit of glasses. So, but we should be able to just offer that to them. So I think if we are looking carefully, choosing our patient carefully, listening to the needs of the patient, trying to put everything the way the patient, what the patient needs, and telling them what to expect and what we can't do. Astigmatism, very, very important. So first get the torics right and then go for multifocals. Multifocal toric, as I said, I have a very low, very quickly I will put in a toric because it really affects the outcome. Biometry, again, very carefully. And again, cost, this is more for us in the corporate hospitals where nothing gets covered. I mean, these multifocals don't get covered. And patients just insist that we want everything covered. So we need to have that discussion before and not have any problems after the surgery. So I think armed with this, we can all get ready and shoot and get a perfectly happy patient and surgeon. Thank you.
Thank you, Dr. Anita. So how many of us are using multifocal IOLs here regularly? Yeah, I think quite a few of us. So I think if there are any problems that you're facing in your patients, we can take the questions later. Just a small size that, we people, because we have dark irises, smaller pupils, so the glare issues and all are a little less. I think it's overrated what the companies and what the, because most of these studies are done from, people with lighter irises. So in our Indian population, it's not so much of an issue.
But the patients read up and come, and the moment you say multifocal, they think that actually you're talking either about a progressive lens or you're talking and, glare hoga.
Obviously, if your patient is not happy with progressives, then he's not going to be a good candidate for multifocals. Thank you, Dr. Anita.